Welcome to the Clinical Thinking Lab, Episode 1. Today's case is about acute mesenteric ischemia, one of those diagnoses where the question is not only what is the diagnosis. The real question is, given what I know right now, what is the safest next decision? This is the shift I'm trying to make in my clinical training, not just memorizing diseases but learning how to think, prioritize, defend a diagnosis, and act before the patient deteriorates. So let's begin. A 65-year-old man comes to the emergency department with sudden severe abdominal pain, vomiting, and sweating for 3 hours. His past medical history is important. He has atrial fibrillation, but he is not anticoagulated. He also has peripheral artery disease, hypertension, and a 40-pack-year smoking history. His vitals are concerning. Blood pressure is 94 over 58. Heart rate is 122 and irregular. Respiratory rate is 28. Oxygen saturation is 96% on room air. On examination, he looks distressed, but his abdomen is soft. There is only mild diffuse tenderness, no guarding, no rigidity. But the key phrase here is the pain is far greater than physical findings. His lab shows WBC of 20,500, lactate of 5.8, creatinine of 2.1. CT angiography shows an abrupt proximal SMA occlusion. There is no free air and no bowel perforation. So, based on these findings, my most likely diagnosis is acute mesenteric ischemia, most likely embolic, from atrial fibrillation. The reason I'm thinking embolic is because he has atrial fibrillation and he is not anticoagulated. A clot from the heart can embolize into the superior mesenteric artery and suddenly block blood supply to the bowel. That explains the sudden severe abdominal pain. It also explains why the patient has pain which is out of proportion to the abdominal exam. In early mesenteric ischemia, the bowel may be ischemic, but the peritoneum may not yet be inflamed. So, patient can have severe pain, but the abdomen may still feel relatively soft. That mismatch is the clue. Severe pain, soft abdomen, high lactate, risk factor for embolism, and CTA showing proximal SMA occlusion. That combination makes acute mesenteric ischemia the working diagnosis. Now, the most dangerous alternative is bowel infarction with peritonitis or perforation. Because once ischemia progresses to transmural bowel necrosis, the patient can develop peritonitis, septic shock, and death. The most plausible physiologic mimic could be another cause of shock and lactic acidosis with abdominal pain, such as severe sepsis, ruptured abdominal aortic aneurysm, pancreatitis, or bowel obstruction. But in this case, the CTA already shows proximal SMA occlusion, and the clinical picture strongly fits acute mesenteric ischemia. The biggest uncertainty is this: how much bowel is already injured? Is the bowel still salvageable, or has it already progressed to infarction? At this moment, there is no free air, no perforation, and no guarding or rigidity. That suggests we may still be a window where urgent revascularization can save bowel. But the lactate is already high, the blood pressure is low, the patient is tachycardic and distressed. So this is not just a stable patient we can just absorb. The immediate threat is bowel ischemia, progressing to infarction, perforation, septic shock, and death. My immediate management would start with airway, breathing, circulation, and resuscitation. I would give IV fluids, keep the patient NPO, start broad spectrum IV antibiotics, and begin IV on fractionate heparin unless there is a contraindication. I would urgently call vascular surgery and general surgery. This patient needs urgent revascularization, either endovascular or surgical, depending on local expertise, anatomy, or patient stability. And if the bowel is non-viable, he may need exploratory laparotomy and resection of dead bowel. The key point is this: heparin is important, but heparin alone does not restore SMA blood flow fast enough. Heparin prevents clot propagation, but revascularization restores blood flow. That difference matters. Now comes the attending asks, why not anticoagulate and observe overnight? My answer would be, because this is acute mesenteric ischemia with shock physiology and high lactate. Observation is dangerous. If we only anticoagulate and wait, the bowel may progress from ischemia to infarction. And once bowel infarction, perforation, and septic shock occurs, mortality becomes much higher. So I would not observe overnight. I would resuscitate, anticoagulate, start antibiotics, and urgently involve vascular and general surgery for definitive management. So now there is another update. The patient deteriorates. His blood pressure falls to 72 over 38. His lactate rises to 8.6. And now his abdomen becomes rigid with rebound tenderness. This changes everything. Now the diagnosis is no longer just acute mesenteric ischemia. Now I have to assume acute mesenteric ischemia with bowel infarction and generalized peritonitis until proven otherwise. At this point, I will not delay for repeat CT. The clinical picture has changed. A rigid abdomen with rebound tenderness means peritonitis. And in this context, peritonitis means likely dead bowel. So the safest decision is emergency exploratory laparotomy with bowel assessment. The patient still needs resuscitation, he still needs antibiotics, he still needs heparin if not contraindicated, but the priority has now shifted toward emergent operative management. The key lesson for me: clinical deterioration overrides the original plan. At first, if there is a SMA occlusion without peritonitis, urgent revascularization may be the main goal. But once peritonitis develops, the question becomes, is there dead bowel? And that requires surgery. So the management must evolve with the patient. This case taught me three clinical pulse. First, pain out of proportion to exam in a high risk patient should make you think of mesenteric ischemia. Second, heparin stabilizes the clot problem, but revascularization fixes the blood flow problem. Third, a rigid abdomen changes the case. Peritonitis means you should not delay for perfect imaging. You need urgent surgical action. My reflection from this case is simple. In clinical setting, the challenge is not only knowing the diagnosis, the challenge is knowing when waiting becomes dangerous. In this case, the safest decision is not passive observation. The safest decision is early recognition, resuscitation, anticoagulation, antibiotics, urgent surgical and vascular involvement, and escalation when the patient deteriorates. That is the real lesson from today's clinical thinking lab. One case, one decision, one step closer to thinking like a good physician. Thank you for watching.